Okay, class, in this lecture, we're going to talk about ligaments. So just like, again, similar format, talk about the molecular composition. So tendons and ligaments, again, are very similar in terms of their molecular composition. They consist of those mesenchymal-derived cells with supporting matrix. The extracellular matrix is primarily fibrous protein collagen, 70 to 80% of dry weight, together with a small amount of elastin, but 1 to 2% of dry weight, and a ground substance, glycoproteins, proteoglycans, and water. The water and the proteoglycans, again, proteoglycans help kind of attract the water, help kind of lubricate and space out the collagen fibers so they can glide over each other when they move. It's both true in ligaments and in tendons. Again, like their close cousins, tendons, ligaments are not avascular. They are hypovascular. About 2% of total volume is occupied by blood vessels. They are there, and depending on the type of vessel, they might have a type of ligament. They may have different amounts of vessels relative to each other. So we'll talk about intra-articular versus extra-articular ligaments, which have two very different compositions. So ligament function. So ligaments, the principal function of ligaments is to prevent excessive or abnormal movements occurring in joints. Therefore, ligaments, like their cousin tendons, are able to withstand higher tensile forces, but may be able to resist in a lot of different directions or multiple directions, depending on the range of motion of the joint. We'll talk about why in a bit. So, additionally, tendons are ligaments, unlike tendons, are sometimes required to stretch and recoil, right, to allow movement to take place, right? So ligaments, again, they're similar to tendons in terms of how they're made up, but in their composition, the relative percentages of what's within their composition may be different, as well as their function might be different, given again some of the unique makeup. So some differences. So again, same basic components, but the precise composition, like the exact percentages and arrangement, are a little bit different. Ligaments tend to have a little bit more ground substance than tendons as well. This has been suggested to be a functional response to shearing actions that may occur within ligaments and joints. And like their differences in their composition allow for the different mechanical properties of each type of tissue. So ligament fibrils are not as uniformly oriented as tendons, right? This allows for multi-axial loading patterns, which is advantageous for what a ligament does to kind of protects a joint. Collagen fibrils and tendons, remember, are in parallel, and they're aligned along the long axis. And in fact, when we start seeing disorder in the axis of tendons, like that's a bad sign, right? So, again, but it's normal for a ligament. They're not exactly in the same direction, all of them. And again, that increased ground substance. Yeah. And again, although again they have similar gene expression, they are oriented just a little bit different here. So here's just an example here, again, between tendons and ligaments, just looking at how they're organized, right? So they're in parallel relative to each other, like they're kind of going this, but they're not exactly one over the same, right? They're a little bit different in terms of their orientation. So ligament function. So ligaments demonstrate non-linear mechanical behavior too. So again, they are relatively compliant under low load conditions. You may hear this referred to this term of creep, where we can apply low load to a tissue and like it progressively elongates, sometimes to a conformational change that's not reversible. That can happen. You see this potentially as well too of chronic use, like if someone with a picture, they have this changes in terms of the joint capsule, which is kind of like an extra-articular ligament. They have increased stiffness with higher tensile loads, so they are pretty compliant under low load, high tensile load. They get a little bit stiffer. The innervation of ligaments, they are innervated to a certain degree as well too. They don't enter the ligament, but they terminate as nerve endings kind of on the surface, and they kind of play a role in motor control. In fact, that we think this may be something to kind of, the focus in on ACL rehabilitation, this loss of this mechanoreceptor potentially in the joint by the severing of the ACL. And again, they're not avascular either, right? Just like their tendons, like they have, these perforating branches of perfusion. We'll talk about that in a bit. So again, we'll get into differences between the two, right? So again, intra-articular and extra-articular ligaments are different, right? Their composition's different. What they kind of do is a little bit different. So the intra-articular ligament, classic example would be your ACL here, which we have depicted here. And then we've got, the ACL here. And then our MCL, right, would be an example of extra-articular ligament. So it's not within the joint. A lot of the research is in looking at ligament healing is often ACL, MCL, if you ever decide to dive into research yourself. So one thing to kind of why it's important to note the difference in terms of the concepts for PTs is that extra-articular ligaments have a great ability to heal. And it's a lot due to their unique physiology. So extra-articular ligaments, like the MCL, again, that's where a lot of the research has been done in looking at extra-articular ligament healing. It's because they have they're highly vascularized, right? They have good blood flow, and the walls of blood vessels contain perivascular and endothelial cells, which may be the origin of a multitude of those MSCs we talked about earlier, those multipotent stem cells, which have a high regenerative capacity. That's why I might see someone who has an MCL injury is like able to, rehabilitate without surgery because they have this really high degree of vascularization, which sets the stage not only for providing blood flow to repair tissue, but they're some of the stem cells which enable the regenerative capacity of that tissue. And importantly, a reduction of angiogenesis within those types of ligaments, extra-articular ligaments, does reduce the healing potential. So the blood supply is crucial for the ability for really any tissue to spontaneously heal after injury. And then like skin injuries and other kind of organ injuries that we talked about earlier, there is a phase of extra-articular ligament healing. It looks very similar, but we'll talk about it. So there's 4 general phases. Phase 1 is initial bleeding, blood filled into the gap of a hemostasis, again, occurring initially. There's a hematoma developed to a bridge where the torn ends are. Phase 2 is featured by inflammation, just like the second stage we saw in typical classical wound healing, and the granulation tissue starts to form with the arrival of fibroblasts, which slowly populate and produce type 3 collagen, a little bit weaker, we talked about versus type 1, and to a lesser extent, type 1. So they laid that initial framework to start repairing the ligament. And then in phase 3, kind of like we saw in wound healing, again, we start proliferating, we start depositing more and more matrix. We develop this kind of vascular neoligament. And then in phase 4, we can think of that chronic maturation remodeling phase where the collagen gets arranged more in that typical axis. It is, again, it's not exactly longitudinal, but it should have a more kind of organized axis than it will be in phase 2 and phase 3. And then we start synthesizing a higher proportion of type 1 collagen. Again, is like much stronger than type 3, which is what the ligament's typically made of. And then followed by long-term remodeling, right? So it's eventually back to the strength it had then initially. So again, here's just an example, again, looking at, normal ligaments and ligament scars, right? What we might see. And again, like this is assuming without any, long-term remodeling, but what we would see normally versus changes. Again, like when we have that scar with healing, there's going to be increased vascularity as it heals and remodels. Initially more type 3, but as we heal, right, it'll start resembling more of that type 1 collagen primarily. Now, intra-articular ligaments, again, are a lot different. And again, most of the research for this is looking at the ACL, right? It's a classical model for this area of research. The healing responses between these two are very, very, very different. And a lot of this has to do with the lack of blood supply, right? There is some, but there's limited, right? There's these paraligamentous vessels which penetrate the ligament transversely. and anastomose with a longitudinal network of endoligamentous vessels. So deeper tissue is less vascular within intra-articular ligaments, but there is some blood supply. So intra-articular ligaments, right, like, are active metabolically. They do undergo cell and matrix turnover, but at a much slower rate, right? Because they are perfused, but at a much lower rate. They're hypoperfused, right? So again, tendons, ligaments, right, are not avascular. That's just not true. Like, they are vascularized, but their blood supply is very, very low. The fibroblasts also have comparatively low motility, low proliferation. So like they do turn over, but it's just a lot slower. Okay. Therefore, after an injury, intra-articular ligaments, unlike extra-articular ligaments, heal at a much slower rate. So again, looking at our ligament healing. So intra-articular ligament healing is almost completely different. We talked about the lack of blood supply. We also factor in as well too, like if there's like damage to other ligaments, right, resultant instability patterns, like that may also affect its ability to heal too. And the other thing to think about as well too, like ACL is a classic example. If we've got a rupture, like the ends separate, right, what makes it really hard for those to tack back down. Really hard. Now, in like kids, you might see an avulsion injury occur, which is a little bit different. So anyone with an open physes, so like that could possibly heal if it tacks back down. However, and anyone who's skeletally mature, where there is like the open physes, you're probably going to see a mid-substance injury, and because of the like the lack or very limited ability for it to heal, you're probably almost always going to need to get surgery, especially if it's a full rupture. So again, because of the lack of ability for intra-articular ligaments to heal spontaneously, surgery reconstruction is like almost always used. You have an autograft or an allograft. And again, it's a lot of this because like you have the torn ends aren't in contact, and it just makes it really hard for that scaffold we talked about earlier to form. So we have the surgery. Now there's a process for this too. Again, like we mentioned, these cells turn over, right? Like our body, like it so it happens here with the grafts too. So this term that we're learning now called ligamentization is an endogenous process where the graft, which is basically when you have an ACL repair or any ligament repair, it essentially is providing a scaffold that you wouldn't be able to produce naturally. We have to provide it with this autograft or allograft. With ligamentation, though, the graft gradually decellularizes and progressively weakens, and then it's eventually repopulated and remodeled. And then again, they provide this scaffold for the body to rebuild the ligament itself. So it's kind of what we're seeing here. There's a graph representing the ACL, and again, we saw often the research is done in the ACL, showing the tensile strength change over time. So again, it's ligamentation where we see like necrosis, that like the graft dies, right? And then it starts to like synthesize itself roughly about 6 months, some people say, and then starts to remodel to where it's eventually back to maybe a point where the athlete's able to get back to play. Now, this is important because like it initially declines and there's apoptosis and repopulation, but it's like it's at its weakest point here, right? So it's why like that there's that crucial phase of making sure that the athlete's like ready to go or not, because if you move too quickly through rehab and not understand like what's actually happening to the ligament, you could run the risk of that a re-injury, because that it's basically a forming extracellular matrix. It's not a mature ligament. So here's a great timeline here showing a systematic review of like different timelines of maturation remodeling. Again, most maturation of an ACL ligament, it's really anywhere from like 9 months right onward. And that's why you typically see people say like, okay, like, someone's probably ready to go maybe at a year to 18 months. It's because like, they're in that maturation phase. Some people even say push it out longer just because, like, everyone's remodeling process is going to be kind of the same. And this is the phase where the ACL is at its weakest if it's rehabilitated or surgically repaired, because, again, it's a matrix being formed. It's not the full tendon that's being remodeled and, all that type 1 collagen. So that is ligaments in a nutshell. And next we'll move on to cartilage.